Good afternoon, and thanks for joining us this afternoon. Before I get started, I just wanted to mention a couple of disclaimers. So, as a urogynecologist, I see females, so this talk really pertains to female population. While some of the treatments can be for males, I'm really focusing on the female aspect of things today. And then, it's for educational purposes only, so does not constitute medical advice for individuals. And any products or medications that I name does not mean that it's endorsed by Johns Hopkins Medicine. So anything I use is more for patient education and illustrative purposes only. So first, I'll just say what a urogynecologist is because I have a lot of patients who are like, I've never even heard of one. So it's someone who specializes in pelvic reconstruction, treatment of prolapse, urinary incontinence, fecal incontinence, recurrent urinary tract infections, pelvic pain, and all the surgical things that go with that. There's two ways to get there. I am an OBGYN trained urogynecologist, which means I did 4 years of residency and then 3 years of fellowship. Alternatively, there are urology trained female urologists who are similar to urogynecologists, but they go through the urology pathway and then usually do 1 or 2 years related to pelvic surgery. So in our talk today, we'll talk a little bit about how common this is, the different types, what can cause it, and essentially what we can do about it. Oops. So first, I think it's important to know what exactly is normal because I think a lot of people aren't aware of what's normal for a female. Most women drink about 2 liters a day, maybe a little more or less depending on whether it's hot or they're sweating. And each time they void, they're urinating about a Coke can worth. So a little over, so between 300 and 400 milliliters is a normal void for a female. Most people go 6 times a day and 0 to 1 times at night. And I bring this up because sometimes I have had patients come in and say, gosh, I go 12 times a day. And then I kind of delve into what they drink a day and find out they're drinking a gallon a day. Well, if you drink a gallon a day, you should be going 12 to 14 times a day because your bladder capacity is only but so large. And so you can drink more fluid, but you will end up having to urinate more. It's not necessarily a bad thing if you drink more. There is such a thing as too much fluid. You can get hyponatremia from that, but most people on an average day are drinking a couple of liters and going about 6 times a day and only having to wake up once or twice in the evening. So today we'll talk about a couple of types of urinary incontinence. There's essentially urge incontinence and stress incontinence. I'm not going to review less common causes because these usually are very rare and don't apply to the general population, but we also see incontinence for reasons such as fistulas, which can be connections between the vagina and the bladder or urethra and the bladder. Sometimes recurrent urinary tract infections, it can be hard to hold it with that. If people are having urinary retention so they can't urinate at all, they can have incontinence from that. And then there are other less, common causes, cancers, masses, stones, that sort of thing that can cause that. But we're not really going to review a lot of that today. The majority of people I'm seeing are falling in the categories of urge, stress, or often both. So how common is this? Well, you are not alone. There are a whole lot of people signed up for this webinar, which should tell you that certainly if you're watching this, you are not the only one interested in this talk. For stress incontinence, the reality is we don't quite know how prevalent it is because I think a lot of patients don't bring it up to their doctors because they think it's either normal as they age or nothing can be done about it. So the prevalence is probably higher than this, but for stress incontinence, it's about 10 to 20%. For urge, the general population about 15, 16%, but as you get in your 70s, 80s, about 30% of elderly patients have this, including men. So it becomes more common as we age. So what is stress urinary incontinence? It's not incontinence because you're having a lot of psychological stress. It's incontinence because you're putting stress on the pelvic floor when, by laughing, coughing, sneezing, running, jumping. And when you do those things, you leak as a result. So that's what we call stress incontinence. It can affect people in many different ways. A lot of times I'll see patients who really enjoy, for example, exercising, and they've kind of stopped doing that because they're embarrassed to go to the gym because they leak. So it can limit your physical activity and going out and enjoying things that a lot of people do on a daily basis. Causes of stress incontinence are variable. It's usually a combination of many things. So the most common reason we find is childbirth. The more children you have, usually vaginally, the higher the risk of urinary incontinence. But getting older, I have plenty of patients who've never had children, or they had cesarean deliveries and they still have stress incontinence. So there are other factors, obesity. So the more pressure you have on your abdomen when you cough and sneeze, that gets transmitted to your pelvic floor. And sometimes your pelvic floor muscles can't overcome that pressure and you leak. So obesity can be a big contributor. Some people have things like Ehlers-Danlos or collagen disorders. Genetics is a big player in this. A lot of people are like, my mom had this as well. Chronic coughing, chronic constipation, things that are putting like chronic sustained impact on their pelvic floor, or chronic heavy lifting, those sort of things can all contribute to urinary incontinence. And it's probably a combination of things for most people, not just one thing. So what can you do about it? Well, you can live with it. It's not life-threatening. If it doesn't bother you, it doesn't bother me. You can see a pelvic floor physical therapist. So these are people who specialize in exercises to strengthen the pelvic floor to help you control it and prevent the leakage. You can do what's called a pessary, which is a vaginal insert to keep you from leaking. And then, of course, you can do surgery for it. So doing nothing is an option. Again, it's only a problem if it bothers you. A lot of women are like, I'm worried it's going to get worse. Most people, it stays about the same. It certainly can get worse as we get older. In some cases, like for example, if someone's immediately postpartum, they find that given a little time, it resolves itself. So it can get worse, it can get better, but for the majority of people, it stays about the same. Pelvic floor physical therapy is a nice option because it's low risk. So it costs you time, but really is low risk of side effects or adverse events from it. So this is a licensed physical therapist who has specialized training in the pelvic floor. And they really have a great understanding of how the pelvic floor functions. With physical therapy and stress incontinence, if you look at the literature, about 50% of women will get some improvement in their symptoms. They may not be completely dry with it, but they often will see a good improvement. And some people will be dry as a result of physical therapy. The muscles do take some time to remodel, so it's not like one visit and it works. I do tell people try for 3 to 4 months before you decide whether it's hasn't worked or not. And of course, you have to do the exercises to get the benefit. So if you're not complying with what they tell you, you're not going to see much improvement there. Physical therapists also treat other conditions like urinary and fecal incontinence, chronic pelvic pain, prolapse, pain with intercourse, muscle spasm, and general pelvic weakness. They have a lot of tools in their toolkit to be able to address various things, but stress incontinence is one of them. Oh, and I will mention in terms of physical therapists, we're lucky in this region, in the National Capital Region, we do have quite a few in this area. In more rural areas, sometimes they don't have any at all. So we are lucky in that we have quite a few in this area we can refer to. Pessaries are these. So they are silicone, medical grade silicone devices that sit within the vagina to support the urethra and prevent you from leaking. Most of the pessaries we use for incontinence, these are actually the ones you're seeing on this photo are more for prolapse. For incontinence, they usually have a little knob on them, and that knob sits under the urethra and keeps you from leaking. Pessaries come in different shapes and sizes. And so we fit you for one based on your pelvic floor width and your what you're coming to see us for, whether it's prolapse, incontinence, or both. So It's not one size fits all. When it's in, it should be comfortable. You shouldn't even know it's there. So we have people stand up, move around. If it's causing discomfort and pressure, it's too big. If it's slipping down, it's too small. So it needs to be just right. But a lot of people use these long term. So we do switch out the Bessary every few years just because you want to have a new one periodically. But in terms of how long you use them in your life, you can use it for years and years, or it can be the only thing that you use. Um, a lot of people nowadays are using diaphragms or menstrual cups, so the concept is very similar. You are going to insert it in the vagina and then pull it down, take it out and clean it, put it back in when you're ready. And some people wear these all day, every day. Some people only use them if they're going to, work out or exercise. But again, usually you'll come in for a fitting for that, and we teach you how to insert it and remove it and care for it. There are some online. I've had some patients say, "Oh, I found one on Amazon or this and that." The difference there is those are not customized for your size and problem. So for some people, those work. For a lot of people, they do not. But they are slightly different than the ones what we're fitting you with in clinic. And insurance does cover this option for most people's insurance. Um, Next, we can talk a little bit about what your surgical options are. So these are the list of things we can offer patients, and I'll talk a little bit about each of these individually. So urethral bulking is, I tell people it's very similar to when people get their filler in their face to get bigger lips or, make them look more youthful. It is a different product than the ones that people are using for their face and cosmetic purposes, but it's a similar concept in that we inject around the sphincter essentially to make it stronger and tighter. So it's giving you a little bit better urethral support. It's usually not permanent, typically lasts a year or two. We do it under camera guidance. But the nice thing is it's just an injection, so it's again pretty low risk in terms of potential complications. I will say most people aren't completely dry with this. It usually reduces leakage, but may not get you where you're not having to wear pads at all. Sometimes I'll use this for people who haven't completed childbearing and they want something to help them until they are done having kids and ready for a more definitive surgery. Or sometimes we do this in patients who maybe already had a sling, and I'll talk a little bit about that, but they're still leaking a little bit. So we use this as to get them a little bit essentially more dry. You can do repeat injections. Each injection typically lasts a year or two, so it's usually not permanent. Your body kind of resorbs the injection over time, just like what happens in the face, right? So that's called urethral bulking. The next is a mid-urethral sling. So this is what is considered the gold standard for surgical treatment of stress incontinence these days. So unfortunately, slings or the material they're made of often has a bad rap nowadays. I mean, patients often hear mesh and they get a little bit nervous because of all the TV litigation that was out on mesh. So a sling is a polypropylene mesh. It's placed by making a little incision under your urethra, and then you tunnel the sling behind the pubic bone, and then you just cut it essentially it exits through the mons or right above your pubic bone, and then we cut it and it kind of retracts back into the muscle. So it's essentially a hammock for the urethra. And the reason this works is because a lot of people have lost support of their urethra and it's unstable. And part of what keeps women continent is when they cough, the urethra compresses itself against the pelvic floor. When you've lost that support, I tell people now your urethra is kind of flapping in the breeze. So that sling restores it. And that's why it works so well. It's minimally invasive, outpatient. You go home the same day. Risks of the procedure are it could be too tight and make it hard for you to urinate. It could be too loose, you still leak some. I also can't promise people it would last them forever. So initial success rate's about 90%. When you get about 10 to 12 years out from surgery, it drops to about 75%. And that's because your body is going to continue to age just like anything else. So I tell people, look, I can get a facelift tomorrow, probably look good for about 10 years, and then it's going to sag again, right? So your body will continue to change, your muscles get weaker as you get older, collagen changes. So, particularly if I'm doing these on younger patients, someone who's 30, I may say, hey, I can't promise this will last you forever. Someone who might be 80, probably will last them forever, right? So some of it is age dependent, how active they are, that sort of thing. You can do repeat slings, and if a sling fails, there are other options, again, such as the urethral bulking. You can't go back in and tighten up a sling once you've placed it, so there's none of that. The main issue with mesh is a potential risk of erosion into the vagina or adjacent organs. That risk is about 2%. So it's very low. So you got a 98% chance that won't happen. The mesh litigation that some patients have heard about was pertaining to these mesh kits that we used to use for prolapse. And the mesh was thicker, it was stiffer, and it was big pieces that they were hooking through the pelvic floor to treat prolapse vaginally. And so up to 30% of those women were getting pelvic pain, pain with sex, mesh erosion with that. And part of why mesh works so well is your tissue kind of grows into it, but that's also why it's hard to get out. So when people had these large pieces of mesh put in, it was very challenging to get it all out. And again, 30% of women, that's a high amount. So those kits are off the market, but we still use mesh in pelvic floor surgery because it's very effective. These particular procedures do not have that 30% complication rate. Again, mesh with slings is about 2%. It's the same material they use for hernia repairs in the abdomen when someone has like a bulge in their abdomen. It's the exact same stuff. So it's been around for a very long time now. It's just how you use it really that matters. So those are slings. Those are the most common thing we do surgically for stress incontinence. You can do what's called a pubovaginal sling. So for patients who really want to avoid mesh, or maybe they had a mesh and then years later they're starting to leak again, we can make a sling out of your own tissue. So we can harvest a piece of your rectus fascia. That's a tough layer that covers your abdomen. And we cut about a 2 centimeter by 4 centimeter piece, about like that, to make a little sling. We do that by making a small incision, similar to a C-section incision, but a little bit smaller. And then we sew that under the urethra. It is a little bit of a bigger dissection, so it's a bit more invasive than the mesh sling. You have to make a larger incision. And obviously you're taking a piece of your own tissue to make that sling. But it works really just as effectively as the mesh. A lot of patients don't choose this because they prefer a more minimally invasive approach, but this is a surgical option that we often do as well. The Birch procedure is basically using permanent sutures to tack up the urethra. We rarely do this anymore because it's just not as effective, frankly, but you're using permanent stitches and attaching it around the urethra and then to a strong ligament behind the pubic bone. And that's a more historic procedure called the Birch procedure. Some people still do it. So sometimes if we're doing an open abdominal surgery for something else, we can do it with that, but otherwise we rarely do this one anymore. So what are risks of surgery? Well, risks of surgery are honestly like any surgery that you may have. So bleeding, infection, allergic reaction to anesthesia. With any surgery, there's a risk of blood clot in your leg or lung. I mentioned pelvic pain as a risk. Slings can be too loose, you still leak a little bit, too tight, you can't pee. Sometimes people do have to go home with a catheter for a few days after surgery. It's not necessarily that their slings are too tight, it's just that sometimes after surgery it can be hard to relax to urinate. Usually after a few days, they're able to go without any problem. I do tell people, hey, look, even if you have a sling and you have a completely full bladder and you go jump on a trampoline, you're still probably going to leak a few drops. It's not going to be the same way it was when you were 20, but the majority of women don't need to use pads or anything anymore after they have this surgery. So I mentioned sling exposure, so that's more pertaining to the mesh. Obviously, you have organs that lie close to that area, so there's risk of adjacent organs. The other thing is surgery does not treat urge incontinence, and we'll talk about that next, but that's when you are having spasms of the bladder, you can't control it, and you have accidents. Slings will not fix that. That's a separate problem. That's more of a neurologic issue. And so when people who have both of those problems, when we do a sling, sometimes they see it gets better, Sometimes it gets worse, sometimes it stays about the same. But in general, slings are not a treatment option for urge incontinence. And then again, there's a low risk of pain after these procedures, about 1% overall. That's really with any vaginal surgery. That's a risk. Anytime you're operating in the vagina, you could have a risk of pain or pain with intercourse. So I mentioned urge incontinence here, so we'll move on to that. That's the next most common cause, and one that we see very prevalent in males and females. Again, it becomes more common as people get older. About 30% of the elderly population has this. So people are not alone with this problem. I have a lot of patients that are going on vacations with their friends and they're worried about needing bathrooms. And I'm like, I guarantee you someone else in your group has the same issue as you, and no one's going to judge you for that. But overactive bladder is defined, essentially you have a sudden urge to go and you can't hold it. So often people will say, man, I have to go every hour. And I go and I feel like right after I go, I have to go again. Or I go and then I sit there and a little bit more comes out. Or I feel like I have to go and then not much comes out because their bladder actually isn't very full. So what's happening there is your bladder is essentially contracting before you're actually ready to go pee. So there's a little bit of a disconnect between how your bladder is functioning that causes it to spasm, and then your pelvic floor can't overcome that and you leak some urine. So that's urge incontinence. And this picture is just illustrating essentially a bladder spasm. The other important thing is we make this diagnosis once we've ruled other things out. So usually when patients are coming in, we always get a urinalysis on them to make sure they don't have a urinary tract infection, because that can often cause similar symptoms. And we check to make sure they're not retaining urine. Urinary retention is very uncommon, but we check everyone because we do find it. So sometimes I've found patients that just, they think they have overactive bladder, but we actually realize the problem is they're not emptying their bladder well at all. So we always screen for those things before we treat for that. I mentioned prevalence is relatively high. So again, we probably don't know the true amount because a lot of people, I think, don't seek treatment for this because they're embarrassed or they think that there's really no options for treatments. Part of what I sometimes do if it sounds like a patient is having a fluid intake issue, is I have them do a voiding diary for me. So what we do is we give you a little, I call it a hat, but it's a little white thing that fits over your toilet. And you write down what you drink each day. And then when you urinate in this hat that catches the urine, and you write down the volume that you go. So often I've found patients who think they have overactive bladder, but then once they do their voiding diary, I realize, gosh, you're drinking 5 liters a day. You don't have overactive bladder. You have what we call polydipsia. So you're just drinking a lot, therefore you have to go a lot. Or sometimes I'll discover that they're saying they have bladder pain or urgency, and I realize, gosh, they're holding it way too long. Every time they void, it's 700 to 1,000 milliliters, which is very, very high and can actually cause bladder damage. And so often we'll have patients complete this so we have a better idea of what their bladder capacity is and what their day-to-day habits are that might be contributing to some of their urinary symptoms. And we usually have people do this for 3 days, and then they send us their diary and we kind of take a look, because sometimes that can help us decide what the next best steps are. So a lot of people ask me, why did this happen? Why am I getting this? The reality is 99% of the time, we don't have an underlying cause for overactive bladder. And I put this this on here to show you, this is just an image essentially of the bladder and the spinal cord and the brain, and showing how complicated it is to actually void. So your bladder is very smart. It has nerve endings that sense when it's full and when it's empty. And you have afferent and efferent nerves that run up and down the spine, goes to this thing called the pons micturition center in your brain, and then send a signal back to your pelvis to let it relax so you can void. So it's actually kind of complicated. Sometimes we're seeing overactive bladder because of an underlying neurologic issue. So of course, if you have an injury in that spinal cord, you very well may have either difficulty voiding or overactive bladder. It's also more common in people with like Parkinson's disease, people who've had strokes. So there certainly are neurologic causes for overactive bladder. People who have MS, it's very common in MS patients. But the majority of the population, we don't find an underlying cause, meaning there's nothing specific for us to treat. We think what it comes down to essentially is aging. Our nerve signals fire differently as we get older. And so there probably is a disconnect in the excitatory side of the pathway that's overstimulating the bladder and causing it to have contractions, and therefore the urgency and the leakage. So the short answer is we don't always find a reason why people are getting it. But there are some things that can definitely contribute to it or make it worse. So I mentioned obesity earlier. Again, part of that is the more pressure that's on the pelvic floor, the harder it is to hold it. So people may have increased pressure and frequency. There are studies that show as little as 8% weight loss can improve bladder symptoms by 50%. So you can get a marked improvement in leakage with relatively little amount of weight loss. Chronic constipation is a big one. When your rectum is chronically distended with stool, it's the same nerves that innervate the bladder. So when people are constipated, their overactive bladder is worse. So I always ask people about constipation because we want to treat that as well. Otherwise, their overactive bladder may not get better. Prolapse, so people who have part of their vagina coming down, they often have overactive bladder symptoms, and it's more because they're not emptying well from their bladder sagging down, essentially. Sleep apnea is a big one. I ask a lot of patients about that, and I've even had a few people say that I've told they need to go get a sleep study and found out they had severe apnea because sleep apnea, long story short, it actually changes hormone levels. You have a change in your antidiuretic hormone. You diurese more at night. So sleep apnea patients often feel like they have to pee a lot more at night because they're actually making more urine at night. So I always ask people if they have it, if they're using their machine, and sometimes I send people for studies because if that's not addressed, they're going to still keep having the issues. Believe it or not, anxiety. I don't know. Some people say they have nervous bladder. I'm a bit of the same way. Like before I get on the plane or if I'm doing a lecture, I'm like, oh, I need to use the restroom. So that can be very normal. So sometimes psychologic contributors. Tobacco is a big bladder irritant. Menopause is a big one because interestingly, your urethra and bladder actually have estrogen receptors on it. So when you lose that estrogen, your urethra thins out, your bladder becomes more permeable. You also lose normally the vaginal pH is basic, and when you lose that, or sorry, is acidic, and when you become menopausal, it becomes basic. So bacteria can colonize easier. But a lot of people find when they're going through menopause or when they have a drop in estrogen, as they get vaginal atrophy, their overactive bladder worsens. So a simple thing we can do is put people on vaginal estrogen, and often 50% of the time, the overactive bladder resolves. Diabetes is a big one because when you're diabetic, if your control isn't good, you actually urinate out glucose, and that really impacts the bladder. Poorly controlled diabetes also damages the terminal nerve endings in the bladder, and that impacts overactive bladder in a big way. So now you know what some of the contributors are. How can we manage it? I will say there's usually no cure. So it's more about managing symptoms. We usually can't completely make it go away altogether. It's like once you have it, you kind of have it. But you can live with it. So some people manage it by, time voiding or we call it bathroom mapping. There is a component with behavioral. Sometimes people are worried about leaking, so they start going more and more often, and then over time, you train your bladder to hold less. So sometimes by increasing the timing of voiding, you can improve your bladder capacity. There are certain drinks and foods that make overactive bladder worse. Tea is a big one. For whatever reason, tea makes urgency frequency a lot worse. Coffee, any caffeine, alcohol, those certainly can too, but that's what we mean by behavioral modification. I mentioned pelvic floor physical therapy earlier. It actually works for overactive bladder as well, and they teach you techniques to help hold it, essentially, strengthen that pelvic floor so you can hold it to make it to the bathroom. Then there are medications, believe it or not, you can Botox the bladder, and then there are some surgeries you can do for overactive bladder, and I'll talk a little bit about those. This is just a one slide shot of in summary, what the treatment options are for overactive bladder. So behavioral, I stated a little bit about that, avoiding, bladder irritants. Sometimes in people who are less mobile, they wake up in the morning and they can't get to their bathrooms in time. So sometimes, particularly like patients who are, in assisted living or who are being taken care of by their family members, having a bedside commode can help, so they can just get out of bed and then pop on the commode and not leak on the way to the bathroom. Increasing physical activity, so the stronger your pelvic floor is, the better control you have. Use of the appropriate incontinence pads. I have a lot of women that come in and they're using menstrual pads to manage their leakage, and menstrual pads actually are designed to hold more viscous fluid, whereas the incontinence pads absorb water much better. And so you really want to make sure you're buying the true incontinence pads rather than using an old menstrual pad that you might have had in the cabinet, because they're going to keep you drier and keep that skin drier than like a menstrual pad would. Stop when the urge strikes. So a lot of people, when they get that urgency, they start running to the bathroom and then they start going, in their pants before they make it to the toilet. What you actually want to do is stop what you're doing, squeeze the pelvic floor, hold it for a count of 10, and then calmly release. And what that's actually doing is the pressure on the perineal body is sending a signal through that pons micturition center back to the bladder to get it to relax. So squeezing the pelvic floor, sitting like on a tennis ball that puts pressure on the perineum, or sitting on your heel, like if you're stuck in traffic in a car, putting pressure on that spot will actually help relax the bladder, help stop the spasm, so then you can make it to the bathroom. So those are some tricks that what we're talking about when we talk about behavior modification. I mentioned vaginal estrogen. Again, menopause changes the acidity of the vagina, the bacterial colonization of the vagina, actually thins out the urethra, as I mentioned, and you see an increase in the frequency of detrusor contractions through menopause. So, simple fix to that, vaginal estrogen comes in 3 forms. There's usually an insert, almost kind of like an ovule, that you put in, and then it kind of melts in there. There's creams, similar to like yeast infection creams. A lot of people will just use their finger for that, or you can put it in a applicator and squirt it in kind of like a tampon. And then there is a ring that is slow releasing estrogen. You put in the vagina, you leave it in for 3 months, and you take it out and put a new one in. So those are 3 forms of delivering vaginal estrogen. I will say as well, a lot of people are afraid of hormones, but there has never been shown to be an association of vaginal estrogen with blood clot, stroke, breast cancer, that sort of thing. Yes, with topical or oral, so like pills, patches, not with vaginal. And so some recent studies have even shown in breast cancer patients, they randomized to people who have had breast cancer, and one group got vaginal estrogen, the other didn't. There was no increase in recurrence rate in people who already had breast cancer who were using vaginal estrogen. So the short story of that is it's safe for long-term use, and it does a remarkable amount for your bladder. It helps the overactive bladder, helps prevent UTIs because it restores that normal microbe, helps with discomfort with intercourse. So it's got 3 really good uses there, and it really isn't absorbed in your bloodstream. So it will not help with bone loss. It will not help with hot flashes. Some of the things that people are taking oral estrogen for, it won't help with those things. It really is just acting locally on the vagina. Of these, I find the creams are more effective for overactive bladder than the ovules or the rings. And part of that is I think because the creams, it's a little bit messier, it gets everywhere, so it actually gets where it needs to go. The ring, not as much. The ring is also a bit more expensive, so I don't see a lot of women using this, but for some women, it's a nice option. So the next option are meds. There really are just two classes of meds out there for overactive bladder. There's older ones, those are called anticholinergics. There's quite a few on the market that's been around for a while, but basically with both of these types of meds, they modify the receptor on the bladder to get it to relax. So it's not contracting as much. So it's kind of a bladder relaxant. One works on the cholinergic receptor, and the other one works on what's called a beta 3 receptor. The beta ones are the newer ones. Sometimes people's insurance won't cover that until they've tried one of the older ones because the older ones are less expensive. But more and more, I'm seeing insurance covering the beta 3 one. A lot of the anticholinergics will cause dry mouth, constipation, sometimes visual changes. You can't take it if you have narrow angle glaucoma. And with long-term use, there might be a slight increased risk of dementia with it. Now, again, we've never been able to quantify that, but I would not give like an anticholinergic to someone who already has dementia because it could potentially worsen it. But dry mouth and constipation are the most common side effects with that, and some people find those intolerable. So we find that long-term use for patients, only about 30% of patients end up continuing those meds. So they do help. They reduce symptoms by about 50%. The other meds are the beta agonists. Like I said, sometimes they are expensive. The good news is they won't cause dry mouth or constipation, but in about 5% of patients, it can potentially elevate your blood pressure. So not real common, but if patients start on that, I have them have a blood pressure check in 2 weeks just to make sure they're not having an elevation in their blood pressure. If they are, they stop it. Doesn't mean just because you have hypertension, you can't take this. Your hypertension needs to be well controlled, but it doesn't mean you're not a candidate for this. Next, I mentioned Botox. Botox, it's the best thing ever. We use it for migraines. We use it for patients like who have spinal cord injuries and have muscle spasticity. And we use it in the bladder. So the bladder is just a big muscle. And so Botox essentially keeps those nerves from firing. The bladder is 3 layers of muscle. It almost looks like a ball of yarn if you were to dissect it out, all the muscle fibers. So we spread out the injections. We use 100 units, do about 10 to 15 injections along the bladder. And it works well enough that you can still void, but it stops that overactive bladder. I will say this is the closest thing other than the surgical implants to a cure. So a lot of women I have who've tried this, they're like, gosh, I can sleep through the night. I'm not having accidents. So it does work very, very well. The risk with Botox is that as urinary tract infection, we do it under camera guidance. We do it in the clinic. It's not an OR procedure. Lasts about 4 to 6 months, so it's not permanent, just like Botox in your face, it's not permanent. You can only have 400 units of Botox in a 3-month period. So if you get it in your face or for migraines, I want to know what dose you're getting so you don't, exceed that 400 units. But most patients are getting 2 injections a year. So UTI is a risk as a result of Botox. The other risk, and this is really less than 1% of patients, it can work too well and make it hard for you to pee. There is no antidote for Botox, so you just have to wait for it to wear off. If you cannot pee, you would need to have a catheter in to drain you. To put it in perspective, I've done Botox, I don't know, probably in 1,000+ patients at this point. I've had maybe 2 or 3 have to use a catheter to drain. So it's very uncommon, but not zero. So most people, it works very well. And again, you can do it in the clinic and last about 4 to 6 months. There are nerve stimulators that you can use as well. There's one we do in the clinic. It's called PTNS. It's very effective, believe it or not, by stimulating the tibial nerve. That nerve connects to the same nerve root as the bladder. so it can actually treat overactive bladder. So there is one that we do in the clinic, but it's pretty time consuming. You have to come in weekly for 12 weeks and then maintenance is once a month. So I don't find a ton of people continuing this because they just don't have the time for it. So there are implants that do the same thing. That's called sacral neuromodulation. It's pretty much like a pacemaker for the bladder. So if some people have ever seen a pacemaker, it looks almost identical. There's two types of batteries, but basically we implant it in your upper bottom, your butt cheek, and we put the battery there, and then there's a wire that connects to it that goes through the sacral foramen, which is where the nerve root is that innervates the bladder. And then that battery sends electrical impulses to get the bladder to relax. So it's pretty cool. It's been around for many years now. This is just an X-ray showing the coccyx and where the wire goes through the coccyx to sit next to the sacral nerve root. And then the second image is showing the battery attached to the wire. It is safe to get MRIs with this. Usually you're not going to set off a airport alarm with it. If you were to get an X-ray, one of those airport screeners, you would see it on that. And so you get a device card what if someone has this implanted. The nice thing about these are that the batteries used to only last about 5 years. Now there's two types of batteries. There's a rechargeable one that you have to recharge about once a month. That's the smaller battery. It looks almost like it's about the size of a USB port. And then there's what they call recharge free, which is essentially the original batteries. You don't have to recharge them at all, but they last a couple of years less. So on average, about 10 years. So when the battery dies, you just swap it out. But it does require an incision to swap out the battery. So Medtronic makes one, Axonics makes one. They're exactly the same. So it honestly doesn't matter which one your surgeon uses because they work identically and the procedure is exactly the same. I'd say Axonics, one of their batteries is slightly smaller, but in terms of efficacy, they're identical. There are some newer options out there. So there's this one made by Medtronic called AltaViva, and it goes in the ankle. So I mentioned that by stimulating the tibial nerve, it can do the same thing that the interstim does, and that it relaxes the bladder over time. This is like brand new. It came out, I don't know, probably a year ago. So not a lot of people are doing them yet, but the battery the stimulator sits over the tibial nerve. The nice thing is it's similar to the PCNS, but you don't have to come in for treatment. So it does it for you, right? There's a similar version that's smaller. It's called Revy, and that's relatively new as well. In this one, you're not implanting the battery, you're just implanting, I call it a little bullet, but you're implanting that only, and then you wear this ankle brace. It's not a brace, but you wear this anklet that has the battery in it, and you wear it once a day, up to twice a day, for at least an hour daily. So it does take some patient involvement with this one. So you've got to actually use it for it to work. But the efficacy is the same as the implants that are put in with the battery as well. It just requires the patient to actually use it, right? So it's patient dependent. But it's nice because it's just in the ankle. We do it under local. We do it in the OR, but you don't need to be intubated for it. And we once it's healed up, you can start using the device. So that's a newer option. There is an at-home one that is essentially a neoprene sleeve that goes over the ankle. I honestly have never had a patient use this because it's not free. But you use it in a similar way of PTNS. I've tried it on myself, so it feels a little bit, almost feels those treatments almost feel like when you've sat on your foot and it feels a little bit asleep. That's kind of what the stimulator feels like. This one has good data on it. Again, it's up to the patients to use it, but you only need to use it 3 times a week, but it is an out-of-pocket expense. Now, some insurance is covering this now, but with insurance coverage, the last I checked with the reps, they said it was about $83 a month. Without insurance, it's like $140 a month. Um, if you buy the whole thing up front, it's $5,000. So for some people, that's cost prohibitive. So I really haven't had any patients as of yet use this particular device, but it is an option. And then in really, really refractory cases, there are essentially diversion of the urine. So you can do that with catheters. Usually that would be a suprapubic catheter. So if someone's leaking so bad, they literally can't control it, urine's just coming out. Sometimes we can put in suprapubic catheters for them. There even is something called urinary diversion or cystoplasty, where you can either augment the bladder or you can essentially make a bladder out of intestine, different things to bypass the bladder so that people aren't having paravoltoval incontinence. Those are incredibly rare. We usually aren't doing that just for overactive bladder. It's more for urinary retention or cancer patients, that sort of thing. But in really severe cases, that is a potential option. And then lastly, if you want to be seen for any of these things, right now, but the majority of my clinic is in Arlington, Virginia. It's in Ballston, where the MedStar ice rink is. So we're on the second floor. The ice rink's on the eighth floor. Parking's $1, so pretty easy to park. I'm there usually 3 days a week, and then at Sibley, I'm here at Sibley twice a month for clinic, and then if I operate, it's at Sibley. So plenty of openings at Arlington. Would love to see you. I know sometimes people who live in Maryland don't want to cross over, but if you take Cambridge Road, it's right there. It's super easy. You just go up Glebe, and it'll be there on your left side. It's actually really easy to get to. So having said that, this is our space in Arlington. It's brand new. It's been open less than 2 years. And they also have, primary care, ophthalmology, colorectal surgery, OBGYN, pelvic floor physical therapy. Sometimes I think twice a week, our surgical oncologists are there as well. So quite a few specialties, internal medicine, family medicine, that are accepting new patients as well. So it's kind of a comprehensive care location if you have need for some of those other things. So at this point, we'll open it up to questions. So I will need to exit out of this to be able to see the chat box. All right. So there are, sorry, I'm going to take my glasses off for this. Can multiple types of incontinence happen at the same time? Absolutely. A lot of times, most patients have more than one, I'll be honest. And we use the same treatments, but we just do it simultaneously. So you would need to address both components, but you can definitely treat both at the same time. Urinary and fecal. Well, the good news is, as you're a gynecologist, we treat fecal incontinence as well. One of the best treatments for that is that implant, that InterStim device. Probably the most effective treatment for fecal incontinence. So a lot of times you can get a bang for your buck, if you will. It'll treat overactive bladder as well as fecal incontinence with that implant. But Urogyn sees fecal incontinence, so we can definitely see patients for that. Does episiotomy contribute to the problem? Short answer, not really. It's more like prolonged pushing, prolonged labor, but episiotomy specifically, that's going to contribute more to potential increase in tears and sphincter injuries and therefore fecal incontinence. So yes, episiotomies with prolapse, not necessarily with stress incontinence. How do you decide between options like Botox, I can't talk, Botox, Bulkamid, InterStim? Well, yeah, so for example, Botox and Bulkamid are treating two different problems. So Botox is for overactive, Bulkamid's for stress. But the factors are, one, what insurance will cover. So sometimes with Botox, a patient will have had to have at least tried one medication before insurance will cover Botox. So sometimes those are the drivers for the steps in which we try things. But like anything I do with patients, it's a mutual conversation and see what they're interested in and what factors are driving them, and that's kind of how we decide. But usually you're not gonna, if you come in for overactive bladder, we're not gonna jump right to an implant. Insurance usually needs documentation that you've tried something else before they'll cover those. Um, what should patients look for when choosing a pelvic floor physical therapist? Specific certification. I honestly don't recall what their degree says, but I would, if you're calling to make an appointment, the biggest red flag to me is when the physical therapist doesn't do a pelvic exam. So if you're seeing a pelvic floor physical therapist, they are doing a vaginal exam on you. They are feeling your pelvic floor muscles. Like, and so don't be surprised. It's not inappropriate for a pelvic floor PT to have you get undressed. They're going to feel where your specific problems are. They're going to test your pelvic floor strength. So if someone's seeing a PT and they've never done that, to me, that's like, I don't know, right? I question whether they're doing the appropriate therapy for a patient. We do have a list of certified pelvic floor physical therapists in our area that we keep in the office that we give to patients as well. I also ask them about insurance because some of them you have to pay out of pocket up front, others take insurance. So that would be my other recommendation is to ask about that. Um, so many treatment options. What questions should patients ask their doctor before agreeing to a procedure? I like any patient, if I'm having a procedure, I would ask about efficacy, long-term success rates, complication risks. Is it something that surgeon does, routinely? Is that part of their usual toolbox? Those would be the main things that I would want to know about, recovery, obviously, from a procedure, how much time off work. Those would be the big drivers for me in asking about it. Can urgency problems indicate things like Parkinson's disease? So usually not. Now, can Parkinson's cause overactive bladder? Absolutely. There's definitely association. If you have overactive bladder, does it mean you have Parkinson's? Very unlikely. Because keep in mind, again, the majority of people that we see with that, we don't find an underlying reason. And frankly, truthfully, the treatment options are still the same, whether you have Parkinson's or not. You obviously would get your Parkinson's treated as well, but from a overactive bladder perspective, we still use the same options for patients. The only difference is if people actually have a neurologic cause, for example, we might use a higher dose of Botox, right? Or we might move to an implant sooner rather than later. So those are slight differences. What is normal water intake for women and what do I recommend? So again, 2 liters a day, fluid overall. Keep in mind you get fluid from some of your foods. So, watermelon, fruits, all vegetables, all those things have water in them. But on days you work out a lot, 3 liters is reasonable. I will say I have a lot of patients coming in and they're like, I drink a gallon a day. And some people think that that's going to help them with weight loss or things like that. There's data that shows initially maybe a slight pound or two benefit with that, but long term, it does not increase weight loss if you drink a ton of water. So a gallon a day, it's fine if you do that, but it's not going to improve your health, and you truly should be urinating about 12 or 14 times a day if you're drinking that much to kind of protect your bladder. Can fibroids cause issues? Short answer, usually they're not causing these problems. So if you get your uterus out, it's neither going to improve or worsen your urinary incontinence. My incontinence is much worse after a body trauma, such as surgery or an injury. Yes, that can be very normal. Like, for example, sometimes people get hysterectomies and transiently their overactive bladder might be worse because we have to kind of peel the bladder off the uterus to get the uterus out. What daily habits actually make symptoms worse that patients don't realize? I would say, so for me, one, the tea, for whatever reason, your body and tea is not great. Most people really aren't doing things to make it worse. I'll be honest with you. It's a lot of it's like beyond your control. What you can control, though, are some of those medical conditions that I mentioned earlier, like keep your diabetes well controlled. get tested for sleep apnea if your partner tells you you snore a lot. Use your sleep machine. Like so many people have apnea, they don't use it. Um, avoid gaining a lot of weight. Like these are things that are in your control that you can manage. And I think people don't realize how much um, they can have an influence on your bladder. How long should patients try a treatment before deciding it's not working? Depends on the treatment. Physical therapy, I say at least 3 months because just like going to the gym, one workout, you're not going to be buff. It takes 3 months for a muscle to start remodeling. So PT, I tell come see me in 3 or 4 months if it's not working. Medications, I give it a month. It does take a while for those receptor uh, modulators to work. But if after a month it's not working, meh, I don't continue it. So it just depends on what the treatment is. Are there warning signs that could be more serious, causing incontinence? Blood in the urine, if you can't pee at all, if you're having difficulty peeing. If the leakage is constant, like it's just dribbling out all the time, that can be a sign of like a fistula. Um, a lot of pain, with urination can be concerning. I'd say those are more, concerning symptoms. And then, of course, fever, chills, that suggests it's more of a UTI, not a overactive bladder. What may cause divots in the bladder? I'm not sure what they mean by divots. They might mean bladder diverticulum, which is you can get these little outpouchings of the bladder, just like you can with the intestine. That's from the bladder contracting so much you get little pockets. So essentially, urethral diverticulum is from really bad overactive bladder. Usually we don't need to do anything about it. If they're getting recurrent UTIs and the diverticular are really big, sometimes we do surgery for that, but it's pretty rare. I did not realize there are difference in pads. Are they clearly labeled for incontinence versus menstrual? Yes. So if you go to any, Amazon or CVS or Walgreens, it will say incontinence. Poise is a big brand. Always makes them, always that makes like period stuff, but it'll say for incontinence. So you don't necessarily have to buy a brand name, but yes, they will say incontinence on it. If someone's embarrassed to bring this up, what's the best way to start the conversation with a doctor? I mean, truthfully, the best way is to bring it up. Like you need to tell us that you're having and no, this is so common. Like you shouldn't be embarrassed because we don't if we don't know that you're having leakage, then we can't help you. So I would just say, hey, I've noticed lately I'm having a hard time controlling my bowels or bladder. I'd like to get evaluated for that. It does, you don't have to give a ton of detail if they're not someone that's going to be treating you, but you should by no means be embarrassed because we've probably seen it all and heard it all, and we want to help you. And so it's nothing to be ashamed or embarrassed about. And again, I guarantee you, one of your friends probably has the same problem. It's just nobody's talking about it. So please don't be embarrassed. Um, how does someone coordinate care if someone has both urinary and fecal incontinence? Again, come see a urogyne. We can treat both. Sometimes though, I there's a colorectal surgeon in our space. I do joint cases with her all the time. So if there is a colon issue, we commonly will coordinate to operate together. So it's just it could be a little bit trickier because you have to coordinate between surgeons, but it's definitely doable. Well, I believe we have hit the deadline for our time. I thank everyone for joining. Hopefully this was useful to you. I don't usually talk this long, so hopefully it wasn't terrible for you. But I would love to see you. Please, you don't necessarily, I mean, your insurance may require a referral, but I don't necessarily need a referral from your doctor, but definitely have appointments open. So, and we can definitely be of service to you. All right. Have a lovely afternoon, everyone.